everybody. I am just doing a little introduction. I've recorded this after the fact. It's just to get everyone understanding what Suitcase Club is, as this is the first time that we have actually recorded Suitcase Club, and we are going to be sharing it hopefully on a monthly basis. The Suitcase Club was originally put together a few years back by my boss, Dr. Albie Defray. It is a way to share travel-related infectious disease cases, case studies, and updates in the travel medicine and infectious disease sort of fraternity. We used to get together just in person, and after the pandemic, this transitioned into a Teams meeting. Our presenters usually in person, and we like to host the meeting every week at our premises in Rosebank. Anyone is welcome to join online and obviously in person if you can make it. We run this in collaboration with GeoSentinel, which is actually GeoSentinel is run by it's a network under the International Society of Travel Medicine. It's a global research and surveillance network, and so essentially a community of travel medicine, tropical medicine, infectious disease experts. And essentially what GeoSentinel does is it gathers a whole bunch of information about any travel related illnesses. We are the Johannesburg sort of branch of GeoSentinel, and if anyone has any interesting travel related cases, they can submit those to us and we submit to GeoSentinel, and it helps us to keep an eye on what type of transmissible diseases are going on around the world, travel related, of course. We do a bit of surveillance work, communication responses, things like that. And it's a nice way for us to keep involved from a South African perspective and also on a global sort of the international scene, and to just keep the data about South Africa up to date as well. Okay. With that, our reporting of cases, it's up on the screen. Obviously, you can phone through to our clinic at any time. We do have a GeoSentinel related email address where cases can be submitted, and you can read up a bit more about GeoSentinel on their website as well. Obviously, Suitcase Club every month is hosted at Travel Doctor Corporate at our premises in collaboration with our Travel Doctor group. We are a group of clinics around South Africa that provide travel health related services. We have clinics all over, from Hoedspruit down to Cape Town. We are all around, and we use the network in order for us to stay connected. If we have a patient that needs to be seen and they are in George, we have someone down in George. And if we don't, we try to, get our patients seen at the earliest convenience. This could be for anything from your pre-travel consultation, vaccinations, malaria prophylaxis, all the way to post-travel. If we have an ill-return traveler, we try to assist those too. Travel Doctor Corporate is our corporate office here in Rosebank. We specialize in corporate travelers, but we do see walk-in clients as well, holiday makers, and we see immigration patients as well. So we do a lot here at Travel Doctor. Thanks to Aspen for hosting this month, or for sponsoring this month's meeting. Aspen is actually the creator and with GSK of Twinrix, which is our hepatitis A and B vaccine. And today we are going to be discussing a little bit about hepatitis, so it made sense to invite Aspen along. Our presenter today is Dr. Kim Pieton. She is an infectious disease specialist. She works here in Rosebank, and we've had a long-standing relationship with Dr. Pieton because we do see a lot of infectious diseases here, just the nature of our work. Dr. Pieton also holds an honorary post as a consultant of infectious diseases at Chris Hani Baragwanath Hospital, and she is a lecturer at Wits University. We are going to hear a little bit from Dr. Pieton now about the hepatitis alphabet, and I'm going to let her take it away. I apologize if the start of the lecture wasn't captured. This was my first time recording a lecture, so I'm hoping that we got enough information that you guys know what's going on, and enjoy.
Actually presents with an acute syndrome. If you do, the common things are nausea, maybe a fever, you might have some right upper quadrant pain, you might be a bit nauseous, not want to eat. On LFT, often the bilirubins are raised. The patient may be clinically jaundiced. Depending on how bad the hepatitis is, usually if it's more severe, you get the pruritus and dark urine and clay-colored stool. But that's not always there. So that's what makes it a little bit sneaky. And most patients will have a small hepatomegaly. In terms of chronic hepatitis, so this is where these viruses are sneaky because they obviously want to be transmitted, so they don't make themselves symptomatic. So most chronic hepatitis is completely asymptomatic. The big clue is fatigue, though, in these viruses that become chronic. So any patient who just tells you, I am so tired, always think about a chronic hepatitis. And then also think about extrahepatic symptoms like arthralgias and skin rashes, and we'll talk more about that just now. And obviously, if you have chronic hepatitis, the issue is, are you going to develop a cirrhosis or even a malignancy? So how do we make a diagnosis? The little clue to test for it in 99% of the case, and you'll see later why I say 99%, is to look on your LFT for raised AST, ALT. So it's a hepatitic pattern. It's not an ALP gamma GT for an acute diagnosis, although you all know if you have chronic hepatitis B or C, then the ALP and gamma GT might go up later on as you start getting cirrhosis. The bilirubins are usually a little bit up, and it's an unconjugated bilirubin. And then depending on how the liver synthetic function is, your albumin's going to go down and your INR will go up. With any virus, the platelets drop. So as soon as you see a low platelets, it's always a clue for malaria or a virus. So similarly with viral hepatitis, normally they have a mildly lowered platelet count, 120, 130. And then with the chronic hepatitis, again, thrombocytopenia, very prolonged INR, but I don't really want to talk about that. What I want to show you on this slide are the incubation period of these viruses. So A and E are very similar. A, 2 to 6 weeks, so usually incubation period around about a month. But B and C and D, look how long the incubation period can go, up to 6 to 8 months. So that's what makes it really difficult to diagnose, and therefore really fuels the transmission of these viruses, because after 5 months, you've forgotten what happened to you when you were infected.
It looks like it's off, and someone said no sound.
Oh no!
Presenting from your side,
Yeah.
I do think it is on from
It's on
Dr.
from your
side.
Can you all hear me? Can someone just write a little message to us and say you can hear or not?
All good.
Yeah,
Okay,
good.
fabulous.
I just put the
Oh,
microphone
that's
Good
from
spot.
this side. Yeah. Sorry.
Okay, so just remember the B's and C's and D's, long 5 to 6 to 8 months versus a month for A and E. So very quickly, hepatitis A only causes acute hepatitis. Usually it's food and waterborne. How do you make a diagnosis? You look for IgMs initially in the first 6 weeks. IgMs become IgGs and they will persist for life. If you're vaccinated, you will have an IgG, and this is a completely preventable disease, and everybody should be vaccinated for hepatitis A, especially those who are at risk. So it's often we find adults who sort of never got it as a child, never had a vaccination. If you've got an alcoholic, if you've got somebody who's HIV positive, if you've got anyone with any specific liver risk factor, always make sure that they've had a hepatitis A vaccine, which is a 2-dose vaccine, usually given up to 6 months apart. So if the A is negative and it looks like A, but there's no IgMs and IgGs for A, you always ask yourself, is it too early? Do I need to repeat the hepatitis A serology? But then always remember hepatitis E, which lots of us don't think about. And I've actually never diagnosed a patient with hepatitis E. I nearly said had, maybe I have and I misdiagnosed them, but always think about hepatitis E. Looks exactly the same. Its transmission is exactly the same. And where it's really important to think about is in pregnant women, because they get severe hepatitis E. And this is where you can develop chronic hepatitis E in immunocompromised people and in pregnant women. Pregnant women, not so much chronic, but they can have a fulminant hepatitis, go into liver failure, abort their babies, and the moms die. So same way, you look for IgMs and IgGs, and always think about Hep E, and Lauren Richards gave a brilliant talk about hepatitis E. How do we treat it? Also, same as A, there's really nothing to do. You give symptomatic management. If they go into liver failure, you're going to treat like you would anyone who's in liver failure and try and get them onto a transplant list. You can try with immunosuppressants and with ribavirin. It really doesn't have great outcomes though. And yeah, I think that's all that I wanted to say over there. Okay, so hepatitis B causes acute and chronic hepatitis. So about 80% of people, maybe even closer to 90%, will be able to clear acute hepatitis B. So it's only about 15 or 20% of people who go on to develop chronic Hep B. How do you get it? With blood or body fluids, through sex, through transfusions, and then the diagnosis and following up the different antibodies and antigens is a complete nightmare. So these are really nice tables, and I hope that you'll start understanding it. But basically, to screen somebody, the first two things you're going to do is a surface antigen and a surface antibody. If the surface antibody and surface antigen are negative, then this is likely somebody who doesn't have acute hepatitis B and has never been exposed to that. However, you can clear those surface antibodies if you've had hepatitis B years ago. So sometimes the Hep B surface antibodies don't persist forever. And so a negative might mean cleared previous infection. Surface antigen positive is where things start getting interesting, and then we want to know if you've got acute infection or chronic infection, but you cannot have had a successful vaccination if your surface antigen is positive. To look for vaccination, you look for surface antibody in isolation, because the vaccine only contains that surface protein, the surface protein. Okay, so then you start getting core antibodies, so anti-HBCs, which can be M's and G's, and also don't go up with vaccination. And then you get E antigens and E antibodies. And the E antigen is basically telling us that this is a very active hepatitis B virus and actively replicating. And then you can get hepatitis B viral PCR. So we measure a viral load like we do with other viruses. So in the beginning with acute hepatitis B, you expect a surface antigen positive. So the third column, you expect a surface antigen positive and E antigen positive because it's actively replicating. You expect a positive viral load. So look at the third column. You don't have surface antibody yet, so that will be negative, versus somebody who's got chronic hepatitis B, who might have surface antigen and E antigen positive, but you might have some surface antibody floating around already. Okay, so it's really, really confusing, but maybe take a screenshot of this quickly, and then I'll go on to the next page and just have a look at it a little bit later. Okay, I'll go back, sorry. Okay, versus chronic hepatitis B, surface antigen will become positive. E antigen can be positive or negative. The hepatitis B viral load is usually positive, even if it's a low positive, and you're not going to have any core antibodies. So that's the most important thing, no core antibodies from an IgM point of view, but you can have from an IgG point of view. So that is what's really confusing about chronic hepatitis B. So take a photo of that, and we'll all read it again tonight before we go to bed. Okay, so the issue with chronic hepatitis B, if you go on for years, is obviously cirrhosis, hepatocellular carcinoma, and there's not really a lot of amazing treatment for those who become chronic. Most people, thankfully, don't need to be treated. So again, it's symptomatic, and most of them are completely unaware of this infection. But you may treat people who are cirrhotic or who are pregnant, and that's to protect the fetus. If there's other risk factors for liver disease, you may treat them. It's highly complicated. Just remember pregnant women, and if you want to give somebody a transplant or if they're cirrhotic. Then we don't really use pegylated interferon anymore because it's such a nasty drug. So most people will get tenofovir. Lamivudine is out now because there's such high levels of resistance, and somehow to single drug tenofovir, not in combination, the barrier to resistance is higher. You can try entecavir, and we try and treat until you start getting antibodies becoming positive and antigens becoming negative. Okay. But I don't even want to talk about this now, which is why I'm whizzing through it. I'm sorry. Because this is a whole talk on itself. There's no ways you can talk about this quickly. All right, so hepatitis B, you can only get Hep D if you've already had Hep B or got active Hep B, and that's because the hepatitis D needs that Hep B surface antigen to infect the cell. So without that, you can't get it. So there's no point even testing for Hep D if you've ruled out hepatitis B. What they say we should do is that every hepatitis B, we should check for hepatitis D, and we hardly ever do that. So these levels are really underreported, and we're not sure. It might be co-infection that you get infected with Hep B and D at the same time, or you might have a super infection, first get Hep B and then get Hep D because you're susceptible. So always remember to check your Hep Bs for the Hep D. Hep D is a lot simpler than the Hep B, so you look for IgMs and IgGs and RNA and the Hep D antigen. Can Ampath do Hep D, Tina? Or do you send it away?
You send it away.
Okay. All right. Treatment for...
It's very infrequently possible,
Yeah.
so that's why.
Yeah.
I'm not 100% sure because we send to different places. Could be, I don't know if we send it to state, or might send it overseas. I don't know.
Yeah, we'll have to find out. Okay, you treat it with pegylated interferon, and this is the nice thing is that Hep B and D are prevented the same way by getting the Hep B vaccination. It's part of the EPI now, so all the children are getting it, which is fabulous. And I think we need to try and do a catch-up of especially vulnerable adults. If you ever see any person as an adult who's Hep B not uninfected and not immune, just send them for a vaccination. You never know what's going to happen, even if they're not high risk at the moment. Say in a car accident, need a massive transfusion, or you can only have benefit from being totally immune to hepatitis B, and then you can't get hepatitis D. Okay, so, and all healthcare workers, yeah, should be vaccinated anyway. Healthcare workers are high risk. So hepatitis C can be acute or chronic. Again, it's contact with blood and body fluids. Body fluids is really not a very good way to transmit hepatitis C. So theoretically, it's on the list that you can get Hep C from having sex with someone who's positive. But it's really not a very efficient way at all. So body fluids is on the list, but it's really with blood and blood products. And we'll see interesting things. And the nice thing about hepatitis C, which why I'm so interested in it, is all the extrahepatic manifestations. It's such an interesting virus. You can get cryoglobulins, kidney involvement, skin involvement, lymphatic involvement, CNS, just about anything. So it's a very interesting disease. And the second reason why I like it is because it's such instant gratification now to be able to cure somebody with Hep C. In the past, you could do nothing for these people. So thankfully, its diagnosis is not as complicated as Hep B. So you look for hepatitis C screening for antibodies. Remember, antibody doesn't mean active. So once you get a positive antibody test, you do hepatitis C RNA. And if that's positive, then you know that you've got a patient. Most of the time, it's already chronic, because by the time you make this diagnosis, they've been sick for over 6 months or infected. They may not be sick. Most of them aren't sick. Infected for over 6 months. And So we said hepatitis B, about 15 to 20% become chronic, and it's much higher. So about 70% of hep C's become chronic. So it's really not a nice diagnosis to get, but at the moment that's fine because we can cure you. So lots of people are worried, come to me with a needle stick injury, and you give them HIV prophylaxis and you give hep B immunoglobulins and vaccinate them and do so much. And the hep C, you say, what must I do? Well, you've just come back and test. And when you're positive, then I'll treat you. And so it's very reassuring now. Okay, so now we've got these amazing drugs, sofosbuvir, velpatasvir, declatasvir. There's lots of virs to cure it, usually for 12 weeks. Every year the treatment gets better and better, and basically anyone who's got hepatitis C now can just get treatment. It's cheaper, it's available, it's not Section 21 in South Africa anymore. And there's really no reason why anyone can't get hepatitis C treatment almost. Okay. Fine, we won't do that. So now let's get on to the interesting stuff. Okay. So this lady is 89 years old. She was born in Croatia and moved to South Africa as a little girl with her family and had many trips back to Croatia. She'd never been married. She'd never had any children. She worked as a legal secretary in an office in Joburg. And by the time she saw me, she was living in a retirement village. She had a private room in the frail care. She had mild dementia. Her mini mental score was around 23, and she was falling all of the time. So she had gone to a hematologist in August that year with multiple neck and jaw swellings. They weren't painful. They'd slowly been enlarging over 4 or 5 months, and she'd seen the GP for this. She had no constitutional symptoms. She was really tired. She had a lot of sika, so very dry eyes, dry mouth. She had lots of nail changes, and she had a painful hyperpigmented rash over her legs. She'd had a seizure following a fall 8 years ago and had initially been on Epilim, which had been stopped. She'd had her gallbladder out 10 years ago. She had dental implants and dental issues, but she wasn't on any chronic medication at the age of 89. She'd smoked for 40 years. She wasn't really much of an alcohol drinker her whole life. She denied all drugs, and she hadn't had any kind of screening investigations. So this is what she looked like. You can see parotidomegaly bilaterally. You can see lymphadenopathy in the left cervical train, little bits in the right side, but the left side was really quite big. She had these nails, and she had this hyperpigmented, painful rash over both of her lower limbs. Her vital signs were normal. She wasn't jaundiced, chest, lungs, heart, tummy, all fine. No hepatomegaly, no splenomegaly. Chest x-ray was clear. Sonar confirmed the clinical findings. She had a normal full blood count. She had a normal kidney function. She had normal liver function, thyroid, serum protein electrophoresis. I don't think that's her folate. That must be her vitamin B12. Autoimmune workup. She had a positive ANA, but it was homogeneous. Anchors negative, calcium normal, ESR slightly elevated. I think the normal's up to 30. And so the GP had sent her for an FNA of the thyroid and of these glands, so the thyroid just showed sort of follicular cells and no malignancy. The parotid and submandibular glands showed small mature B cells, flow suggestive of a small B cell clonal lymphocyte population. And the submandibular lymph nodes showed no atypical malignant cells, no granulomatous inflammation. So really nothing exciting. So what do you think? So, I mean, we kind of know what the diagnosis has to be now based on what we've discussed already. So which one, what do you think is going on and how is this working? Yeah, so there's extrahepatic manifestations of hepatitis C. Exactly.
How did you get there?
Very good question. And that's also what I was asking. So think of all the mimickers, yeah, and all the sort of things that we would start testing for when you've got someone where you have no idea what's going on. So the usual ones: HIV, autoimmune diseases, a malignancy, syphilis, the great mimickers. Okay. So what would you do next? Test for Hep B and C, do HIV and syphilis, get a rheumatologist, her ANA was positive, do another biopsy, get a derm consult. So I say all of those, do all of it. We haven't got a clue what's going on. And so I'm not sure what triggered it, but somebody did a hepatitis C antibody, which was positive. And then expecting it to be negative, like it often is, they did a viral load, and her viral load came back as 2 million. Did a genotype on that, and it was genotype 1b, and so a diagnosis was made of chronic hepatitis C with extrahepatic manifestations.
Wow.
Yeah. So I think the lesson in this is, what would have triggered us to test for Hep C? Nothing. Because in all those previous slides, I said ALT, AST, as soon as there's something funny on the liver, we all test. But as soon as, pardon? The fatigue, yeah. But every patient we see tells us they're tired, Tina. I'm tired. So as soon as we've just got to have a list of all those mimickers in our mind, and as soon as something is not adding up, do a syphilis, do a Hep C, and look more. Okay, so a little bit more about hepatitis C. It's a flaviviridae. I think these are actually some of your slides in here still, Tina. Some of these might look familiar to you. It's a single-stranded RNA virus, and this is why it was always so difficult in the past for treatment and for vaccine, because you know RNA viruses are so dodgy to try and pin down and vaccinate for, and they don't check their genome, so they keep making mutations, and so we still don't have a hepatitis C vaccine. It's got 6 major genotypes, of which the most common is 1A and 1B. As you can see, all over Europe, all over North and South America, all over Australia. South Africa has got all of the genotypes, but genotype 5 is quite exclusive to us. The rest of the world doesn't have that. Genotype 2 in West Africa, genotype 4 in the Middle East, Egypt, and Central Africa, genotype 3 in Southeast Asia. So look at that, 75% of people with hepatitis C is silent and don't know that they're infected. And so this is where the problem comes in with transmission. Okay, I don't want to talk really about this, except to say that there's 3 structural proteins and then a whole lot of non-structural proteins. And all that's important for is so that you can understand where to make a diagnosis, because the PCR will choose a piece of the genome that is specific to that virus. And so the PCR chooses, I think it's on one of the other slides, but anyway, I think it's the NS4 area to read to say, yes, this is a positive PCR. And then also the structural proteins are targets for therapy. So what makes us think about doing it? Usually a patient with a deranged LFT, anyone with hepatitis or cirrhotic liver. You start with serology. If it's positive, you go on to a PCR, which is a quantitative PCR and gives the viral load. And if that's positive, they do gene sequencing to see if it's genotype 1A up until 5. At the same time, if you make a diagnosis, we always want to know if they're hepatitis B infected, if they're HIV infected. Because we're saying it's blood and body fluids, we want to know about other STIs and other bloodborne infections. So the STI screen at the same time is a good idea. Remember I said that the incubation period can be up to 8 months. So a negative test early in the beginning may need to be repeated later on, because the antibodies really only become detectable after about 10 weeks. So people get screened, and maybe you've thought about it, and then the test comes back negative, and then we say, okay, well, that's fine. So always remember to repeat it in someone with the right exposure, and it's an ELISA. And remember also Hep C can have false positives and cross reactions. So autoimmune diseases often give positive Hep Cs, but that's only the antibody that will be positive. If you have a positive viral load, that can't be the autoimmune disease. So remember I showed you that lady had an ANA and skin and all things that look lupusy or autoimmune, but a viral load rules out the fact that it's more than, that it is actually more than autoimmune. So window period of 8 weeks. So remember that, okay. Okay, fine. PCR, genotyping. Okay, so there, NS5B, that's the target for the genotyping to sequence to figure out what genotype it is. And that's all lab stuff and virology stuff. So we're interested in the clinical stuff. So how do we get it? The vast majority of hepatitis C around the world is in injection drug use. Next is probably sexual, although remember I said it's not really efficient. The other ones are all kind of related to blood. Transfusions, healthcare workers in a sort of environment where you could get needle stick injuries or be exposed to large volumes of blood. And then about 10% of people, we don't know how they got it. Where do we get the most hepatitis C around the world? So because of the injection drug use, a huge amount of it is in the first world where they've got access to drugs and have the money for those kind of things. But we'll see something really interesting in terms of what happened in Egypt. So Egypt, prior to the very recent past, had the highest prevalence of hepatitis C in the whole world. Does anyone know why? So they think that it was from the schistosomiasis eradication program. And about 30 years ago, there was injectable, was it praziquantel? Must have been another drug that was being injected to the population to try and control bilharzia. And unfortunately, there wasn't enough education in clinics about sterilizing syringes and needles, and they didn't have enough stock to have single-use things. And so vast numbers of the population had the same needle stuck in there.
Oh.
Terrible, terrible. So there were huge percentages of the population, and something like 70% of people between the age of 50 and 70 in Egypt, 70% were hepatitis C positive. And nobody knew about it for years afterwards because they were
Asymptomatic.
They were asymptomatic. And then those moms were having babies, and their babies were getting infected, and their partners were getting infected. And so a huge percentage of the population were cured of bilharzia and infected with hepatitis C. So there was a massive program with the, I can't remember who initiated it now, CDC or CDC Africa or something like that. And they went to Egypt to try and show the Egyptian government, and the Egyptian government looked at stats for looking after these people, because by now they're all cirrhotic, they all got hepatocellular carcinoma, they're all in liver failure, and the massive amounts of money to look after that versus curing this and treating them with the new drugs. So there was a huge campaign over 1 year. They treated over 1 million people by getting the drugs much cheaper, having huge availability, opening massive amounts of clinics, educating the nation. And by the end of March, after 1 year of this program, 1 million people were treated at state expense for free for them. And they have basically eradicated hepatitis C in Egypt. I mean, the most amazing story. So after you finish reading the Hep B serology and trying to understand that, then Google Egypt and hepatitis C and read that story. It's such an amazing story. Okay, so now we're back to my lady. Unmarried, no drug use, no children. Maybe she had sexual partners, but she was a bit demented, or maybe she didn't want to tell me. But really very little to say how this woman, no transfusions that she could remember, how she got infected. So I tried to look and see, was there something special about Croatia, like Egypt, that she might have been infected as a child before she left? But there really isn't. It's the same as most countries around the world, highest prevalence in injection drug users, people on dialysis, HIV positive, is people with STD. So nothing really exciting about living in or coming from Croatia. Okay, I think this is a repeat of that previous slide. What genotype is where? So 1A, 1B, the dominant one. Okay, so this is how hepatitis C progresses through time. And look how long it takes, 30 years to get to the end point. 90% of that time you're asymptomatic. You start off with a normal liver, you get acutely infected. 80% of people develop chronic infection. You have a chronic grumbly hepatitis for years and years and years. Of those people, 20% will develop cirrhosis. And then the risk of carcinoma is 1 to 4% per year if you're on the cirrhotic side. If you have hepatitis B or HIV or you abuse alcohol, your risk of developing the cirrhosis and the carcinoma skyrockets. And so that's why I'm saying we must all have a Hep B vaccine, just in case we get this. So what are the manifestations? Are to look for the extrahepatic. So hematological, they often can look like B-cell lymphoma, like Our Lady with the lymphopoietic tissue, which seem to have masses and whatever, but they do actually have an increased incidence of non-Hodgkin's lymphoma. Cryoglobulins, aplastic anemia, so Hep C can wipe out your bone marrow. Most viruses cause a low platelet count. Skin rashes, porphyria, it looks like porphyria cutaneosa, lichen planus, necrotizing vasculitis, glomerulonephritis, nephrotic syndrome. Sorry, don't know why my nose is getting dodgy. Okay, what's all with the back? Thank you. It can cause positive antithyroid antibodies. Some of these patients are diabetic. Sialadenitis and salivary glands it likes. Corneal ulcers, uveitis, polyarteritis nodosa. Thank you. And then weakness and neuropathy. And so it involves every single organ just about. And now this is a chart showing us the drug sort of progression and how amazing things are and when things started. So when did they first identify it? In 1978. Then they characterized the hepatitis C polyprotein in 1993. Were able to work with in vitro models in 1999. And then interferon was the first drug used to try and treat it in 1986. Then interferon ribavirin dual treatment, 1994. And then the first DAAs, direct acting antivirals, came out in 2000, we started being tested in 2003, approved in the late 20, as we started approaching 2020, and then started coming out with these just amazing drugs. I think this is more or less the same, just less busy. So in 2014, the game changers started arriving. So remember, no virus, actually no infectious disease almost we ever want to give single drugs to because of the development of resistance, and specifically things like hepatitis C and HIV. So in 2014 was a major breakthrough with the rollout of sofosbuvir and ledipasvir. 2015, everyone else jumped on the bandwagon and started making these drugs like mad, declatisvir, dasubivir, paritaprevir, ombitasvir. And what they're targeting are these, remember I said, remember the non-structural proteins. So they inhibit the NS5As, that non-structural protein. They polymerase inhibitors and they protease inhibitors, same as with the ARVs, protease inhibitors. And so what we want is combination of these drugs and trying to work out what the best combination is for a genotype. Because of those 6 genotypes, we know some of these drugs work better. And that's why I initially want to know the genotype of the patient to try and choose. But now there's pan-genotypic drugs. So it doesn't actually even matter what genotype you are anymore. You just take a pan-genotype drug and treat the patient. So these are the different regimens which are recommended depending on the different genotypes. Generally, you get 12 weeks of the drug in combination. Very few side effects. Patients hardly know that they're taking these drugs. You need to do very little monitoring, an LFT and an FBC at the beginning and after a couple of weeks, and then at the end you do a viral load. And huge suppression, 95% in almost all of these regimens have a sustained virological response, which means an undetected viral load, and that viral load never shoots up again in the vast majority of those patients, so it's a cure. What was the problem? Okay, so this is the pangenomic, the occlusive, sofosbuvir, valpatisvir, where you don't even need to test theoretically to know what genotype it is, because it works well for all those genotypes. And hugely effective, hugely safe. So sustained virological response in, so this is for sofosbuvir, declatisvir, sofosbuvir, valpatisvir. 95%. I mean, it's almost unheard of in the treatment of any viral infection to get these kind of results. Really exciting. The issue in the beginning, though, was the cost. And that was the limiting factor in this, in that just about nobody outside of the very elite first world was able to get access and pay for these drugs. So the cost has come down hugely now. As I said, it's not Section 21 in South Africa anymore. For a 12-week course, it's under 10,000 Rand for a cure. Yeah.
So medical aid.
It's now the medical aids will pay because it's approved. And people who are not even on medical aids are able to save, because the nice part is you don't need to get the treatment tomorrow. If you do not have a cirrhotic liver, you've got a year or two to save the money and to save 500 Rand a month, and in 18 months you're able to pay for it. The cost comes down every year. The availability is so much better. The drug interactions are minimal, so you don't need to worry about all the other medication the patients are on. I mean, you've got to check, but generally it doesn't interact much. And it's just really the best thing that's ever hits infectious diseases, I think, one of the best things. The only issue is the gastros always want to treat these patients, and I like treating them. So to work up a patient with hepatitis C, to try and work out where they are, and this is not just for hepatitis C, but for hepatitis B, for patients who have alcoholic liver disease, any kind of liver disease. In the past, when we wanted to start someone on treatment, you'd have to have a liver biopsy, which is a complete nightmare, jolly sore, has complications of rupturing the liver, bleeding, really is quite a nasty thing. But now you don't even need to have a liver biopsy, but it is useful to have a FibroScan, which is a little sonar that they do over the skin like a normal sonar and shoots waves through the liver and looks to see how the wave moves through the liver, and depending on that tells us if the person has got cirrhosis and what degree of fibrosis the patient has. And so you get a fibrosis score, and in the past it used to guide treatment to say if your fibrosis score was this, then you qualify for treatment. Now, because it's getting easier and easier and easier, really everyone should get treatment. So it actually doesn't matter what your fibrosis score is, apart from prognosticating, because obviously if you've got a cirrhotic liver, and you treat the Hep C, you still got cirrhosis. So this is useful to know. And then the second thing we would do is an E-score. So it gives you 2 scores, the FibroScan. It gives you an F score and a CAP or an E-score to tell you, and that's more for a fatty liver. So NASH and ASH, and now in HIV, the name's changed completely as well. But that's really useful that you don't have to do a liver biopsy on those people either to tell them how much fat is in their liver. So you get a CAP score and an E score, which is useful for prognosticating, but really doesn't mean you only treat when it's a certain number anymore. Okay, so it's just, again, just showing you F0, you've hardly got anything. F4, you've got a cirrhotic liver. And that's that. So how did this lady do? So we gave her, she was in that frail care, like I said, without any family except a lovely nephew who said, I can pay for it. I'm happy for her to have it. At that stage, it was still Section 21 and cost about 15,000 Rand for the course. And he said, absolutely, I'll give it to her. And so they bought it. She had it. She had no side effects. And I think she's died now because I saw her once afterwards and then I haven't seen her ever again. And I think all the rest of her stuff caught up with her from a dementia point of view. Interestingly, all this lymphatic tissue, all slowly, it was still there when I saw her after treatment, but it had about halved in size. The rash over her legs, that vasculitis had gone, and her platelets had actually come up. So that was really interesting.
Wow.
Yeah.
Do you ever determine how she got it?
No, never figured it out. Yeah. She's in that 10% of people where you don't know how they got it. Yeah.
I have a question. The FibroScan, where do you get it done?
They've got it at the Donald Gordon.
Okay.
So I just send my patients across there.
Okay.
And it's quick. You don't need a trained, I mean, you need a bit of training, but the machine works out the score. So basically the person just holds the sonar probe against there, and then the machine fires this wave through the liver 10 times or whatever and works out the time for each wave, and then works out an average and then tells you the number. So it's not like a sonographer where you have to go and be trained, and it's quite difficult to be a good sonographer. Yeah. This is pretty simple.
And I have another question. Does state pay for Hep C treatment now? Or will they?
They will. The problem is, they are allocated it, but the budget always gets used up instantly. So I've chatted to them at Barron, I've chatted to them at the Gen, and they say, yes, we can get it, and yes, send the patients, and then I'll phone the patient and they'll say, yeah, I haven't got any treatment yet. And so it's still, and I mean, 9,000 Rand is a drop in the ocean, exactly, but it's just not the motivation to get it through. And then a lot of the time they'll say, okay, well, you're an infection drug user and you're HIV positive and you never take your ARVs, and then these people sort of get left behind unfairly. But it is theoretically available. Yeah.
It just would make so much sense to treat them rather than treat all the complications down the line.
Well, when you look at the case study of Egypt, it's just mind-blowing what they managed to achieve.
I've got a question.
Yeah.
In that initial sort of window period, 10 weeks, I think you said, are the infected people infectious? I mean, is the blood infectious?
Yeah, they are infectious, and actually it's similar to HIV. You get a bit of a peak of viremia, and so very infectious during that stage, and then your body will control it, and you see, like with HIV, a low viral load, and then as the years go by, a rising viral load.
It means a danger to blood donation.
Exactly. Yeah.
They screen for it to see.
Yeah, and I'm not sure what they do, if they do a viral load to get around the window period, not just an antibody test. Yeah.
I've just posted online. If anyone has questions from our online audience, please can either post them in the chat, or you are also welcome to unmute yourself and post them and ask a question if you would like to. And anyone else in the room? Questions, comments, anything? Alrighty.
Can I ask, Kim, will you remind us for needle stick injuries, the relevance for healthcare workers?
With Hep C?
Yeah, because if you don't have a needle stick injury, it's often like the forgotten test that people forget to do. So if you,
Exactly.
I'm not sure what the current guideline is when you should check.
So you always check
at baseline.
at baseline. Yeah. But then you need to get past that 8-week window period. And sometimes it's not just 8 weeks.
Yes.
So I say do it at baseline, do it at 8 weeks, do it at 4 months.
Okay.
And then as soon as they're positive, you treat.
Yeah.
You should also test the
patients.
Patients.
Yeah.
Needles.
Exactly.
Yeah.
Exactly.
Okay.
They could also be in the window period.
Yeah. No, that's the problem.
Yeah. But luckily in South Africa, this is not a huge problem. Thankfully. It's getting more.
I've never had hepatitis C test after all the needle sticks.
That's why I bring it up.
Exactly.
It's forgotten.
Yeah.
We all obsess about the HIV, but it's actually, I mean, HIV is bad, but this is.
Yeah. So in our setting, where sex is not a good transmitter, where up until we started getting Nyalpe and other drugs, but Nyalpe you smoke, so it's not huge. And most of our people can't afford IV drugs, so that's been protective for South Africans.
Yeah.
But it's rising, the Hep C incidence.
Actually, when you talk about it is they do smoke it, and sometimes what they do, that and then they do the Bluetooth.
Yeah, okay.
Yeah.
Yes,
When you do
exactly.
injection,
They share the blood, not the drug in the
they
cold
can get the
form.
high from.
You're right, exactly. Yeah. Scary.
We have a question of, it's from Rena. Are there any typical neurological symptoms from Hep C?
No, it's normally not central. It's normally peripheral. So neuropathies, mononeuritis, multiplex type things, rather than a meningitis or an encephalitis.
And there was a question on how long the window period is. So I think we addressed that. We said 8 weeks, but up until 4 months, we would still test.
Yeah. So remember that the incubation period can be 6 to 8 months.
Okay.
So theoretically, then that could prolong your incubation, your window period, if you are only going to get sort of past the incubation period when you're in your 6th or 7th month, post-infection.
But then the test should be.
Yeah, hopefully. Hopefully.
Yeah. Okay.
But what I'm trying to say is the longer your incubation period is, the longer your window period is going to be. So whilst we say 6 to 8 months, thankfully it's not everyone who take that long to get infection after a window period. So you're not going to have antibodies if you don't, and so your window period is going to be longer. The rule of thumb is sort of 8 to 10 weeks.
Right. I think that's it from the online audience. I'm going to close the meeting online, and then we're welcome to still chat around here. But thank you everyone who's attended online, and we will see you next month. So we'll send out our topic and everything in the next sort of 2 weeks, and we hope to see you then. All right. Thank you so much.
Thank you.